Everybody, welcome to our executive director Rita, and we have today David Davidson, Dr. David Davidson, a past Academy president. We share a connection to Buffalo. I wasn't born there, but my parents were, and both diehard Bills fans. And then we have Dr. Rich Bouche, who is a very well-authored, well-published, well-respected in the podiatry community, ran a fellowship, and is now, I guess, in semi-retirement, still coming back for academic type ventures. And this is one of them. We're going to do an episode today. I kind of planned this around some of the old school techniques, the lost arts that many new practitioners have not keyed in on as much in the rush to, let's say, get to an MRI or something that seems more expeditious. And I kicked this around with David and Rich, and we came up with a format. We're going to talk a little bit about some provocative testing, and Rich is going to tell us about some of the sensitivity and specificity tests that he developed, and then David is going to offer some of the practical things that he learned over how many decades, David, did you practice? However many, honing down to a diagnosis. And I've tapped on his shoulder more than a couple times, and it's always good to have like a lifeline call that you can bounce ideas off of. So that's something I would encourage physicians that are even seasoned to do, to be able to do some rounds or tap into a colleague. So Rich, I'm going to have you sort of take the lead here with talking about your concepts of provocative testing, and start with some of the ankle ones and work our way down the ankle and foot anatomy. So take it away, Rich.
So this concept of provocative maneuvers, I kind of discovered that about 12 years ago. I started thinking about that, and that was the motivation behind this presentation. I've been presenting this for about 12 years, and it's quite a simple concept. Is with the demands that we are all under for fee-for-service medicine, whether you are in a private practice, group practice, or corporate medicine, and that mode of medicine, that type of medicine, is likely to change here in the near future. But with that comes great demands on our time, because we have to ask the question, why is the physical exam a lost art? And there's many reasons for it. There's less physician-patient contact. There's a great demand to see 30, 40 patients a day. And even when I was at Virginia Mason, in the waiting room was a kiosk with a recording, an audio of the CEO. And he basically would tell the patient, you will get to spend 7 minutes with your patient. So make sure you list your problems in order, and likely you'll get to one or two, but you won't get to all of them. And that was the ultimate as far as registering to me that how much time during this short period of time will we spend on actually touching the patient? How much time will we be able to perform physical exam? And the answer is minimal. I mean, very limited time. And now with the demands of EHR, we're all under the same pressures. And it behooves us to be able to work efficiently. And whether we stay with a fee-for-service model, or in the future, if care becomes capitated and integrated, which likely it will be because of financial, economic reasons, we will all have to rethink how we interact with the patients. And one part of that is going to be we need to maintain our ability to examine the patient. I just went through a knee surgery on my left knee. I had 4 opinions, and one of the docs that saw me, I had to ask them to do a physical exam because they were concentrating on the X-ray and MR. And that's happened in our field as well. In Seattle, I know physicians who don't even examine the patient. There's one well-known doc in Seattle. Every time I see a patient of his, I ask the patient, did they touch your foot? No, they didn't touch my foot. Looked at the MRI and scheduled surgery. And that, to me, is a glaring problem. And so we don't want to fall into that. And this group of us here today, you know, we've all been trained well for physical examination, but it has become a lost art out of necessity because our time demands limitation of time with the patient, too much emphasis on reading X-rays and MRIs without realizing their limitations. So that's what drove me to come up with this provocative maneuvers evaluation. And I don't necessarily want to lecture in this forum. I'd like to be able to engage everybody who's here today. Can you still hear me?
Yeah, we're good.
Because I just lost my screen for some reason.
Well, I wanted to just add that.
Okay, there I'm back.
Go ahead.
I'm back. For some reason, I lost my screen. But so this concept is very simple. And I can certainly give examples of how I applied it. And it's not mine, though. Okay, the idea is mine. And that's what I want to share with you. I want to share with you because you can do this on your phone in your leisure time. I mean, you have access to PubMed Central. You can get that on your phone. You can look up whatever you want on your phone. It's amazing. And a lot of this that's how I did. I would take one topic at a time. I have 70 topics that I have documented with a provocative maneuver, okay? And a lot of times, depending on the entity, you'll have 10, 15 choices. And I can give examples of that. And a good example applying to sports medicine is use of the tuning fork to diagnose stress fracture. That has absolutely no value in my practice because there's no sensitivity to it. There's no specificity to it. And it's a test that I don't really want to do because I would not rely on that. So why does that keep coming up? Oh, you can use a tuning fork to diagnose stress fracture. I don't think I ever have, maybe one time, okay? But that's just an example. We have to deal with this misinformation that's been propagated through the years and get down to the nitty gritty. Every problem I list, no matter what it is, plantar fasciitis, posterior heel pain, navicular stress fracture, in your mind, when I say that, you should say, well, I know the test for that. I know the provocative test for that, okay? And this does not take the place of a physical exam. We all know how to do our physical exam. We check the vascular status, neurological status, dermatologic status, musculoskeletal exam. What is that? That's us inspecting the patient. That's us checking range of motion, muscle testing, and palpation. That's it, palpation. And then, hey, you get your diagnostic test. So where does provocative testing fit in? It fits in right after you palpate. And sometimes palpation is a provocative test. But whatever the problem is, it's good to have in your mind, what is that one test, preferably it being evidence-based. And unfortunately in podiatry and in our field, a lot of what we do is not evidence-based because there is no evidence. There's no level 1, 2 evidence. So the question, do you base it on evidence-based medicine or eminence-based medicine? Eminence-based medicine is us sitting here talking, saying, well, what do you do? What do you do? Yeah, a lot of times we rely on that. And a lot of this information that I've provided, I've come up with some of my own provocative tests. But before I did that, I looked at what was in the literature and what has evidence-based behind it. Because again, each problem, we want to get it down to 1 or 2 tests so we can get on with the rest of the workup. that being diagnostic testing, coming up with a differential diagnosis, and then finally making the diagnosis. It is very important, especially in a sports medicine practice, that we come up with a diagnosis before we start to treat. If we have no idea what we're treating, empiric treatment has no role for the athlete, in my opinion, because the stakes are too high. And you're going to get burned if that's the way you practice. All plantar fasciitis, we cannot assume all plantar heel pain is plantar fasciitis. Yeah, a lot of times we do that, but we can get burned on that. Same thing, all posterior heel pain is not Haglund's deformity. So the onus is on us to be the best we can be, and that's what's going to set us apart from everybody else, because we have people out there not even touching the foot. They're just basing things on MRIs and then doing surgery, basing surgery without examining the patient. That to me is just unbelievable. Okay.
Rich, so can we have you explain, and you had a beautiful example of a sensitive versus a specific test with the ankle syndesmotic injury, maybe to start off.
I'll put this, I'm gonna share my screen and
One
we
second,
can do
Rich.
that.
I mean, I think one of the things that is really so important in before you do this is to just talk about your point of time management is critical here. You're right. The constraints on the private practice are incredible, and they're only going to get worse. And your people are generating less income and doing more work. So the time it becomes an issue, especially with new patients, whether they're sports patients or not sports patients. People need to realize that first visit is critical. They're not going to be able to do everything you want them to do in 7 minutes, right? So
correct.
Time management is critical here.
So to finish what I started to say, you can do this, and that's what I want to share with you. There's pathology template. And so say you're going to look up navicular stress fracture. Oh, I don't know anything about that. Okay, well, look it up. And you know, what's the name of it? Does it have other names? Okay, navicular stress fracture, that's it. You may have some background notes like, oh, this is a very highly misdiagnosis, common in athletes, jumping sports, etc. And then you need to review what are the provocative tests. I challenge you to look it up and see what's available, and you'll find nothing, very little. There's one study that discovered this N spot, which is the navicular spot. It's a specific spot on the navicular, which we'll go over. We'll use that as an example. But that is the one test. And there's another one. It's the demi-point position that dancers use. They get up on the ball of their foot. Now that's a very utilitarian test because it can also diagnose other things. But to me, if you're looking for a navicular stress fracture, those are the two provocative tests. One is palpation of the end spot, and two is have the patient assume a demi-point position with load, and it will reproduce their pain because the talonavicular joint is vertical, and the talar head will be going into the cup of the navicular, causing symptoms there with load. Okay, and those are the two tests that will help you make an efficient diagnosis. Then you can get on, and then the question to ask, okay, those two tests are positive, now what do I do? Okay, well, with a navicular stress fracture, you can try and get an x-ray. There is one x-ray view that is specific for that. You can actually dorsiflex and supinate the foot. You want that central ray perpendicular to where the fracture is between the first and second cuneiform. The only way you'll image that is with that special view. If you get an AP, mortis, lateral, and a lateral, you won't see the stress fracture. So that's one trick. Beyond that, there's no question. CT scan is the test of choice. I would not fall into the one limitation of MRI is it can show you bone edema, but it may not show you the stress fracture. You may not see a fracture line. So you could diagnose that as a stress reaction and treat that inappropriately with a short period of immobilization. And I got numerous examples of that. The MRI said, oh, this is just a stress reaction. We'll have you back running in 3 to 4 weeks. Trouble is, we get a CT scan and it's grade 2 stress fracture. Okay, so again, the inaccurate diagnosis led to inappropriate treatment. That's why you have to go with the best test to give you the information. And in my opinion, after an x-ray, if that's equivocal or uncertain, then you want to get a CT scan, and that will make your diagnosis, and that can dictate your treatment as well. So I can use that as an example. And when you're looking at testing, you're going to see this. They're going to talk of sensitivity of a test. That's the ability of a test to actually identify a patient with the problem. So in this case, what test would identify the patient with a stress fracture, the navicular stress fracture? And then when you talk of test specificity, that's the ability of a test to tell you when you don't have the diagnosis. So you do a maneuver and it's negative, that tells you, if it's a highly specific test, that you do not have this problem. Now, a good example that we're all familiar with bone scans and CT. A bone scan is extremely sensitive. It will not miss anything, but it's not specific. It tells you something is wrong, but it doesn't tell you what it is. So that's a good example of a highly sensitive test that's not going to miss a diagnosis, but it's not specific because it's not specific for any one problem that it could be. So then that's why after you get a bone scan and it's positive, what would you get? You'd get a CT because you want to see the bone better three-dimensionally. And the CT will say, yes, oh yeah, there's the stress fracture. Oh, there's the osteochondral cyst, whatever. Okay, so that's the way we apply these tests. Now, sometimes you talk about sensitivity and specificity. There is no research on it. So you have to come up with your own way of making the diagnosis just to survive. So I'll give you an example. I'm going to share my screen here with everybody. There's 12 participants here, I see. So let's see if we can get this to work. Here we go.
And I loved, Rich, by the way, that I thought the ankle syndesmotic injury, and I don't know where that is in your program,
okay. You want me to do that?
was one of the most elegant, you know, in terms of this sensitivity versus specificity. David and I were talking sort of prior and after some of our discussions that not all the provocative tests fall exactly in line with a perfect sensitivity and specificity criteria, but some of them for sure do, and that it at least gives you sort of a hook to hang your hat on. So I'll let you take over with however you want.
Okay. Now that we have all the introduction out of the way and you know about the template, this is applying the template. Now, normally, the only reason I put additional tests, you can see that right there where my arrow is. I normally don't have those in there, okay? But I just put them in there because this is a great example of, this is all from the literature. And all these tests, you can do them all, but again, they're not highly specific, nor are they highly sensitive. So why would you waste your time? So that's my point.
Rich, maximize that PowerPoint.
Pardon?
So maximize the PowerPoint. Can you make that larger?
Yeah.
Up in the,
how's that?
either way. Can you hit
Okay.
the little, that's much better.
That's better, Rich. That's better.
Okay,
Much
so
better.
here we go. Ankle syndesmosis injury. This is a timely injury because as we all know, this injury is not as uncommon as we're made to believe. We were told that, oh, you know, maybe 5% incidence of high ankle sprain. Well, if you look at injury statistics for the NFL, NBA, et cetera, you'll find that it's more 15, 20% now. So, you know, the distribution has changed. The lateral ankle sprain, maybe 75%, 80%. High ankle sprain can be as high as 15, 20%. Then you have your medial ankle sprain pulling up the rear. So we need to put that in perspective. This is more common than we think, and it's missed a lot, okay? And the obvious ones aren't missed or shouldn't be, but there's ones that present and they look like they should be normal because the x-rays and the imaging studies are normal, but they're not because they cannot function. And that's why these provocative tests are critical. and we'll talk specifically about that. So
Can
we
can
gave
we
it
back up a little
the,
bit, Rich?
yeah,
Okay, can we back up just a little bit?
go ahead.
So, because I want to keep this pretty clinical. So a patient comes into your office on crutches with a sports-related ankle pain, twisted the ankle on the field. Okay. So what's your first, once you run through the basic systemic history and physical, when you zero down on the ankle, what do you do before these tests?
So the first thing I would do if someone just walks in and said, I injured my ankle, that's where the history comes in, because that's going to dictate what the physical exam and the rest of the workup is going to look like. So this patient comes in, and yeah, what if they say, and you can see there on the screen, it's mostly associated with external rotation injuries or forced dorsiflexion injuries. And we're all familiar with ankle fracture mechanism, the Logie-Hansen and the Weber classification, and there you see it. Pronation, external rotation, pronation, adduction, supination, external rotation. So in the history, maybe we can get an idea. Let's just say it's a football player, got his foot caught, and some lineman laid on his leg from the lateral side. That would put it into the category. Once we think, well, yeah, that's probably pronation, external rotation, or pronation adduction. That gives us a suspicion right there, the history, that, oh, with those mechanisms, I have to be thinking of, well, maybe it was a medial ankle sprain, or maybe it was a syndesmosis sprain. So right there, the history, and it's going to be more in depth than I just presented there, but that gives you a clue that you're going to be thinking about a syndesmosis sprain, okay? And then you're going to do the physical exam like you normally do, but then we're going to get to provocative tests. And let's just look at that clearly here. When we talk of sensitive tests, what test am I going to do where when it's positive, we will identify the patient with the problem. And there you see them listed. Syndesmosis palpation is 92% sensitive. That's pretty good. 92%. So that's why that's number one on the list. Now, you have to be able to know where the syndesmosis is. Now, that seems like it's elementary, right? Sometimes I ask residents, where is the syndesmosis? Palpate it. And they're not in the correct spot, if you can believe it. So you have to know where the anterior tib fib joint is. And that is a joint. That's separate from the ankle joint. It's a joint in and of itself. And so syndesmosis palpation will reproduce pain there over the anterior inferior tib fib ligament. And that has 92% sensitivity, which is very high. Another test is called the single hop test. Very simple. You just have the patient standing there and have them jump on the involved foot. If they have a syndesmosis injury, they cannot do it. Whether they're black or white, it doesn't matter. You know, white men can't jump. Well, black men can't jump either if they have a syndesmosis sprain. Nobody can jump. Okay, so keep that one in mind. Inability to perform a one-time hop maneuver is 89% sensitive, highly sensitive. And then to complete that, you do an external rotation stress. The knee's at 90, the foot's at neutral. You take the foot, you stabilize the tibia, and you externally rotate. And I have a picture of that under fluoroscan or x-ray, and that will seal the deal because you will appreciate the instability most of the time. How many times, you know, the external rotation test is 71% sensitive. So between those three tests, you have high sensitivity what the diagnosis is. And then as far as specificity, go down to specific tests. The squeeze test, it's very simple. You go mid-calf and you squeeze the tibia and the fibula together. Believe it or not, that test is 89%. It's called the cotton test or the squeeze test. That test is 89% specific. So if you don't have that, if that test is negative, you probably don't have a syndesmosis sprain. But when you do that test, you will get pain out of the proportion to what you would think. Those patients are in severe pain. Okay, and that's basically it. Those are the sensitive tests that I do and the specific tests that I do. And then if you were in a situation like you posed there, Ben, you said this athlete comes in with a fresh injury and I do this testing and this is positive. What would I get? Other than a stress test under fluoro or x-ray, which I'll show you in a second, I would get an MRI. An MRI will show you great soft tissue. It'll show you the soft tissue really well, and you'll be able to come up with a tentative diagnosis, because that will dictate treatment. And what we're looking for here is instability, just like we are with any ankle sprain. If the ankle joint, if the syndesmosis is unstable, or you think it's unstable, then it needs to be completely worked up, because it does indicate surgery here. This is something you would not want to sit on if you said, oh, I'm pretty sure this guy's unstable, you know, and you're going to find it out eventually, because if you treat him conservatively for 4 to 6 weeks in a cast, he gets out of the cast, he can't do a single hop test, or you do all your maneuvers here and they're still symptomatic. That's because you missed an instability, and that's a bad problem, okay? Because instability needs to have surgery, okay? That is the moral of the story. You do not want to sit on these cases. You definitely want to do the testing, validate with MRI, and then you get on with it. And if you don't do the surgery, then you refer to someone on your team that does the surgery, okay?
So do you, Rich, do you do, I might be jumping ahead a little bit, on all these provocative tests for this diagnosis and others, you do these tests to help achieve a diagnosis. Do you also use the same test to determine treatment success? Discharge the
Yes.
patient, you repeat these tests at the end?
Yep.
Okay.
Yeah, a good return to activity test for someone with a syndesmosis injury, whether they had surgery or not, would be have them stand there on the involved foot, have them do 20 single hops on their foot. And if it's not right, they won't be able to do 1 or 2. They'll be just grabbing their leg, okay? If they can't do that, they're nowhere near into getting back to activity. So later on, you know, we could talk about return to sport for lateral ankle sprains. You know, there's not really good level 1 evidence. Maybe in the last couple of years, there's been some, but it's all eminence-based. You know, it's based on our experience. But at our clinic, you know, there's 4 criteria we use to return an athlete after a lateral ankle sprain. And everybody should kind of follow that suit. You know, although it's not level 1 evidence, that's what I'm saying. So we have to be careful there. That's why this document is dynamic, because who knows what's going to happen next year. They may find out something that we may need to change on there. So we're constantly changing these templates, okay? Now, a couple pearls. This is a Ben pearl right here. If tests are all negative, there could still be a syndesmosis injury. And there are cases where the x-ray is normal, your stress exam is kind of normal, but you suspect, you know, what's going to make you suspect? You're going to go back to these provocative tests. What do you mean you can't jump up and down? Why do you still hurt when I press your syndesmosis, when I palpate there? That means they could have a subtle syndesmosis injury. And the way to figure that out, other than imaging, would be to stick a scope in there and directly visualize the syndesmosis. That's what's done these days. A lot of times they just stick the scope in as a diagnostic tool, and in 5 minutes you can see, well, holy cow, that thing is really unstable. All the ligaments are torn. Well, that answers your question. You're going to fix it on the spot. Okay, that gives you the answer to your dilemma. Well, why is this patient still symptomatic? And then also one caveat is to make sure when we get into these injuries, pronation, external rotation, pronation, abduction, you got to be careful of the high ankle sprain. The high ankles, or the high ankle fracture, excuse me, the fibular fracture, the Weber C. Weber C is the high one. And, you know, a lot of times we get x-rays and we're looking low. But if they have those mechanisms, you have to get the x-ray higher and you have to palpate higher so you don't miss a Mason-New fracture. Okay, so that's the caveat. Always check proximal. And then I will end this segment with an X-ray. And this is an X-ray on the left. That's post-ankle sprain. You can see some swelling there. Everything looks pretty well aligned. But you do the external rotation stress, the Kleiger's test, and there it is on the right side. What happens here is the knee is at 90 degrees to prevent splinting. The foot is at 90 degrees to the leg at the level of the ankle. I have my left hand on the tibia. I have my right hand on the foot in a neutral position, and I simply externally rotate. And as I externally rotate, this fibula is going to move laterally and posteriorly, mainly posteriorly, believe it or not. There's a lot of play anterior posterior. So when it does, the talus is abutting the fibula, and as it displaces, it causes this huge medial clear space. Anything over 5 millimeters absolutely would be suspicious, okay? And you can compare it to the other side. The ankle joint, the medial gutter, lateral gutter should all be fairly symmetric as far as spacing goes. And this is quite obvious. When you see this, you know what happened. That syndesmosis is sprung, despite the fact it has overlap here. And here, look at all the overlap. If you just use X-ray criteria, you'd say, this is good. This looks good. You got a nice space here, no fractures that we see. Everything looks great. So we're going to put you in a cast for 3 weeks. You'll be fine. Well, little do you know, you kind of missed the fracture or the syndesmosis injury.
Before we jump to the next situation on the ankle testing and return to sport, what do you think of the hopscotch test that I guess Doug Ritchie, you had mentioned, sort of espoused?
Yeah, I think that maneuver, the hopscotch or the jump, the load test when you're jumping either unilaterally, bilaterally, it can be used for lots of different things. This is one of the main indications right here is syndesmosis injuries, no question. Because if you just treated this patient via surgery or via conservative care, these are the tests you're going to do. So you have them do that single jump maneuver, and they have to be able to do that 20 times without a problem. If they can't, you're going to be thinking of something's wrong here. It's also a criteria used to assess stability after an ankle sprain. They do this there's more to it than just the hopscotch test. Okay. But it's kind of a utilitarian test, you know. I mean, the single hop test is used for tibial stress fractures as well. So it has many indications. And I think Doug Ritchie mentioned that the hopscotch test for one of his criteria for return to sport post ankle sprain. I believe he used that hopscotch test.
And I know you're going to do ankle impingement next, another great test. Before we get there, what about the lateral ankle sprain and the Ottawa rules? How accurate and easy to perform and consistent did you find the Ottawa rules?
Yeah, well, the Ottawa rules, it was introduced in '93 by two physicians out of Ottawa Civic Hospital. And the reason they set that up and they came up with that was to avoid unnecessary x-rays. So that particular Ottawa ankle rules, that should be well known to everybody. And it's beyond the scope of this little get together today to really go too much in depth, but there it is right there. And it is validated. It's validated. First, it was validated for adults over 16, 18 years old. And now it's validated for kids as low as 6 years old. Okay. So basically it's a set examination. You basically have a malleolar zone, which is the ankle, a midfoot zone, which is the midfoot. And if the patient complains of pain in one of those two, like, where do you hurt? Oh, I hurt up in the ankle. Okay. Well, if you have ankle pain, let me take an exam. Let me examine you, and you examine the distal 6 centimeters posterior aspect of the lateral malleolus and the medial malleolus. And the reason you're examining the posterior aspect is where's all the ligaments mostly on the lateral side, anterior, talofib, calcaneofib, they're anterior, right? So you're going to come in from the posterior aspect. Why? So you know as well as I do, when you have an ankle sprain, anywhere you touch them, they hurt. But if you palpate posteriorly, you will identify more likely evidence of a fracture, okay, especially on kids as well because of the growth plate. Okay, you definitely want to separate the growth plate from the ankle sprain, the soft tissue injury. So simplistically, you palpate the distal posterior aspect of the lateral malleolus, palpate the posterior aspect of the medial malleolus, and if either one of those are positive and the patient cannot take a step immediately after the injury or take 4 sequential steps after you see them later, post-immediate after the injury, then you would get an X-ray. And likewise, if you palpate the navicular or you palpate the 5th metatarsal base and they have pain there and they can't walk on it, that would mandate a foot X-ray. Okay, so that essentially is the criteria. It's very regimented, and it's basically palpation in 4 areas: lateral malleolus, medial malleolus, navicular, and 5th metabase. And you know as well as I do, if you had some outlier there where they hurt somewhere else, you certainly wouldn't want to miss that. So if you're suspicious and you can validate it, you get an X-ray. And what will that mean to the patient? It means the patients 40% of the time won't need an X-ray. It's going to save a load of money. So that's why they did it. In '95, they came up with the Ottawa knee rules, a similar criteria to limit the number of X-rays for knees. Okay. They should probably have one for the back as well. How many times are back X-rays obtained when people have back pain? A lot, probably a lot of wasted X-rays. There should be criteria for that to say, oh, this is a little bit different. You know, I'm palpating your vertebrae back there and they're hurting. So yeah, if you suspect an X-ray problem, you're going to get an X-ray. So that was the thought behind the Ottawa ankle rules. And there's plenty of studies to validate it. Some large level 1 studies have validated it for adults and children now as well. So that's been a good thing.
All right, do you want to continue? I think you were jumping over to anterior ankle impingement.
Yeah, I wonder if anybody has any questions about what we just talked about so far. I wouldn't mind hearing some questions if people have them. Don't be afraid.
And you can also there should be a feature to write your questions if you don't want to say them during the program, and we'll get to them.
And again, I don't mind going through these, but
we're not going to do all of them, Rich, but we've got, I at least want to do the ones we covered on the outline. I think
yeah, I have no problem with that as long as people are getting something out of this, or if they want to hear specifically. I just loaded up 10 of the 70 I have, and you know, this is my opinion. And you know, again, you can do this on your own with your phone. You could do this while you're listening to me. You could sit there and say, well, hell, he didn't say this because there's a new paper out maybe that I didn't find out about. I'm always doing that. Sometimes when I'm sitting around doing nothing, I just pick up the phone, and it's amazing what I find sometimes. It really is. Like falls risk. They got a specific criteria for falls risk now. There's 4 tests they use to identify people who are likely to take a fall. And that's invaluable for podiatrists, but I never heard that. Okay, I've never heard that up to this point, and I just did that the other day on my phone, just wasting time. That's what you do when you're retired.
Rich, I would be hard pressed not to get X-rays on 99% of these ankle injuries that are coming in. just in
Yeah,
this
Dave.
area, in this environment, this medical legal environment that we're dealing with.
Yeah, that's a good discussion to have, because when I first saw the auto ankle rules, I said, oh man, you got to be kidding me. But then I started to use them, and I have used them to a degree, but I have a low threshold to get an x-ray. Let's just say that. But it has improved my clinical exam skills, like this concept of approaching the fibula from the back. That is invaluable, because
Right.
you see a sprain at 3 days old. Anywhere you touch them, they hurt. They hurt everywhere. It's like,
Right.
come back in 5 days and we'll examine you for real, you know. But a lot of times the patient may say, well, how the hell did he know? He didn't even take an x-ray, you know. So I get your point. But again, if we're evidence-based, this test is here to stay. Okay, and whether we like it or not. But I hear
I think
what you're
also
saying.
the context of the Canadian healthcare environment, where maybe they were looking to ration out some of the studies because of the way that healthcare is dispensed in Canada. That might be part of it as well.
Hey, clearly, I think X-rays are way overutilized in our profession and orthopedics in general. But yeah, I just wanted to raise that point.
That's a good point. That's a great point, though. You know, something to think about. It really is. And, you know, whatever you're going to do, as long as you can validate it, you have to validate it clinically, have a suspicion. And then I always like to get a test to validate my suspicion. And that can save a lot of legal action, in my opinion. You know, and then just be honest with the patient, you know, just say, hey, you need to come back in here in 5 days so I can examine you for real. Otherwise, we can get a bunch of studies we don't need, you know. So things to think about. It can change the way you practice, that's for sure. So any other questions? Okay, anterior ankle impingement. That's a common problem. It's the most common problem for ankle arthroscopy, ankle impingement, either bony, you can get an x-ray for that, plus your exam, or soft tissue. With soft tissue, the x-ray is going to be normal, and 50% of the time the MRI will be normal as well. So here's a good example of, are you going to rely on diagnostic studies to help you out? If you are, you're going to be sorely disappointed, because it's not going to help you out like you think. You think you're going to see a bunch of scar up there on the MRI? You should, but you don't, and they still have these symptoms. So thus, these provocative tests. There's 2 of them. One I've used for 30 years, that's the skier's crouch test. Basically, assume a skier's crouch position, and we all know what that is: hip flexed, knee flexed, ankle dorsiflexed. Keep heels on the ground, feet positioned straight ahead, and you have them slowly, the involved sides compared to the contralateral side. You could have them do them both at first, bilaterally, and then one, and then the other. Compare the unaffected side to the affected side. Usually when they get down to a certain degree, they will get a sharp shooting pain that is readily reproducible with this maneuver. And then a non-weight bearing study, it's called the Malloy Test. There's a study based on this. They did a study, and the way it works is basically you take your thumb and you're going to sequentially palpate over the medial, central, and lateral ankle. So first we start anterior medial. I press the anterior medial ankle with the foot slightly plantar flexed, and then I dorsiflex while I keep the pressure anterior medially. So think of what's happening. There's scar tissue there, reactive tissue, inflamed tissue, and you're pushing it into the joint, and you're holding it there, and then you're dorsiflexing the ankle. That's what's happening. So what happens? They say, ouch, that really hurts. Okay, now if you do that when you don't put your thumb on, it's a non-weight bearing skier's crouch. It doesn't really work. Okay, the reason the skier's crouch works because you're bearing weight on it. You're getting enough load on it to make the tissue symptomatic. So again, you're palpating anterior medially, and then you dorsiflex. oh, that hurts. Okay, centrally, oh, that hurts. And then laterally, same thing. And when it's anterior lateral, you can have a Bassett's ligament, an accessory ligament over there. And we don't know if that's an accessory ligament or if it's just scar tissue. One way to sort that out is the only time you plantar flex and it reproduces their pain is when they have an accessory ligament. So you palpate laterally, you dorsiflex, they hurt when they dorsiflex. You plantar flex and they hurt when they plantar flex, okay? If it's just anterior medial impingement, you put your thumb there, you dorsiflex, they hurt. You plantar flex, they don't hurt with plantar flexion centrally. They don't hurt with plantar flexion medially. But if they hurt with plantar flexion laterally, then you highly suspect a accessory ligament, Bassett's ligament. Okay, so that would give you the diagnosis. Then you get your diagnostic studies. A good diagnostic tool is a diagnostic injection. If you inject their ankle with local, they will get 100% relief, okay, as long as the local lasts. So if you're using lidocaine, 1 to 2 hours, Marcaine for whatever, 3 to 4 hours or so, and then appropriate treatment based on that. Are there any questions on that? So you can see how we're applying these. You just go down the list, and this is what you want to, when you say anterior ankle pin, what comes to your mind? Skier's crouch test and the Malloy test. Okay, when you get the syndesmosis, think of those sensitive tests, the Kliger test, the palpation test, the hop test, and then the specific test is the squeeze test. Okay, so pretty basic. Just start thinking about that, and then share this information. People say, well, where the hell did you get it? I got it just by making some of this up and just by looking. It's out there, but it's not in any one place, okay? That's why we've presented this. This is usually a good workshop for about 3 hours with a little bit of a break in there. With 3 hours, you can do it justice. You can get through a lot of pathology, and it gives people a good idea of how these were developed. But you could do it all the same. Everybody here tonight can do your own templates. We'll go for is the next one navicular stress fracture? Is that all right?
Sure.
Go for it.
Okay, navicular stress fracture, commonly missed. When people come, when the kids come in, 16-year-old kid comes in, he's got plantar fasciitis. Number one, plantar fasciitis in a kid's not that common. So that should be a little red herring right there. It's like, oh, really? You've had pain for 6 months and nobody knows what it is? Okay, well, start thinking stress fracture, okay, because it is commonly missed. And you'll find out why, because unless you examine the patient with this end spot, you will not figure it out. You can palpate the navicular, but it's very specifically on this end spot where the fracture is that they will have symptoms, okay? And the symptoms are vague weight-bearing induced arch pain with no index injury, no traumatic event. Most are sagittal plane stress fractures between the first and second cuneiform. I'll show you an x-ray in a second. And then I see a subset of patients, usually older patients, maybe rheumatic patients. They get transverse subchondral fractures of the navicular. And those are commonly missed as well. And again, high index of suspicion, positive end spot, and then get the appropriate diagnostic testing. Here's another one, the one-legged forefoot hopping. When you do that demi-point position, or you have them hop on it, another application for your the hopscotch kind of maneuver. So end spot, it's between the tibialis anterior and the EHL. It's very specific. If you move one thumb breadth medially, you'll miss it. If you move one thumb breadth laterally, you'll miss it. It's got to be on that spot because that's where the fracture is. Okay. So let's take a close look at this x-ray. And here, now we're looking at this. This is a CT scan. CT scan, you can't beat it. What you see is what you get. 3-dimensional, excellent resolution, the best we have in the business. And you can see the fracture line starts dorsally. There's an accessory bone there, an os talonaviculare. For some reason, I don't know if they're associated with that accessory bone, but a lot of these accessory bones, that's exactly where this fracture starts. It starts as a little crack, and then it propagates down. This is a grade 2. A grade 1 would be just dorsal. Grade 2 would be partial propagation from dorsal to plantar. Grade 3 is all the way through. Dr. Saxena came up with that classification with Brian Fulham and applied it to a study they did on stress fractures, which I think they came out with 2 studies discussing surgical, possible surgical management for these, when to do surgery, when not. And I would add a 4th classification. That's when it fractures through and displaces. It involves 2 joints, talonavicular and navicular cuneiform. That's a disaster, by the way, because you have 2 joints that are involved now. But in this case, it's a grade 2. Sometimes these can be treated conservatively, but you got to pick them up early. You wouldn't want to sit on this for 3 months and then be backtracking and try and get it to heal. So here you can see the fracture line, the sagittal line. And, you know, this looks obvious on the CT scan, but sometimes in surgery, you get in there and you can't find the thing. Okay, it's really crazy that they're hard to pick up sometimes. But this is how they present. And this spot right here, where my arrow is, that is between tibialis anterior, which is medial, and EHL. That's the first ray right there, or the cuneiforms, then the first ray. Okay, so you can see it's snuck in there, and that's where the end spot is. And you could obviously see when you load this foot, the talus, the head of the talus just kind of compresses against the cup of the navicular, and you will have symptoms there with that loading maneuver.
A clinical question. So you have a kid come into your office with pain, medial foot, positive end spot test. Could it could still be a stress reaction, right? Not a stress fracture.
Yes, it could.
So CT, or you order a CT regardless?
A lot of times,
How do you make that differential initially?
Okay. My thought process on any bone problem, when I see a patient and I think they have a bone problem or a joint problem, okay? I don't know what, but I think they do, because I'm pressing on the bone and they're jumping off the table. Okay, so that's good enough evidence for me. So then, and I don't know what it is. The x-ray, say the x-ray is normal or equivocal. Then I would get a bone scan. I get a bone scan, and a bone scan's not used much anymore. Okay, but I love the bone scan. Everybody goes to an MRI. They say, oh, the MRI will tell you. No, the MRI, I mean, you could see bone edema, but I see bone edema on 90% of athletes I see, because they're jumping up and down on their feet all day, right? But that doesn't mean there's pathology there. But if I get a bone scan and that's hot and it's localized, that means there is something wrong there, right there where it's hot. It's focalized there and there's uptake. And the uptake means 2 things. There's bone activity and increased blood flow. That's all it tells you. It doesn't tell you what it is, though. So yeah, if the bone scan's positive, then I'd get a CT, and that's what you'd see. Okay. If you get an MRI on these, a lot of times you'll see bone edema, but you won't see this line. So you'll say, well, that's a stress reaction. It's not a stress fracture. And that's the pitfall of an MRI in this case. When I want to see bone, I go with the best test I can. Now you can get what's called a CT fusion or a SPECT scan, single photon emission computerized tomography. Now that's a combination of a bone scan and a CT. But my rationale in a case where I don't know what's going on and the x-ray is normal, I don't know this kid's going to need a CT. Why would I have them exposed to all that radiation? For my convenience? No, so I get a bone scan first. If that's positive, then I'd get the CT. Would I get a CT if the bone scan's negative? No. If the bone scan is negative, that tells me there's not a bone problem or a joint problem. Yeah, it could be a soft tissue problem. Yeah, then get your MRI or do an ultrasound or whatever. You know, so anyway, we all have to develop that thought process of how you're going to work this up. That's how I do it. You know, if the x-ray is normal or equivocal and I suspect a bone or joint problem, I get a bone scan. If that's positive, I get a CT. If it's negative, I don't get a CT. I started thinking of other things, like maybe an MRI, maybe some other testing. But it all should make sense. And all I'm doing is validating my clinical exam. And what was that? Oh, he had a positive end spot, and when he loaded his foot, it hurt. So high on the list is, man, I think you may have a stress fracture. I hope I'm wrong, but I think you may. Okay, so that's how you're going to get to the diagnosis. And then once we have it, then go ahead and treat it. But one thing, we may disagree on treatment, but we have to agree on the diagnosis. I mean, we just have to agree on what we're treating. And so I would say, you know, in certain situations like dealing with sesamoids, there's a tendency not to want to work those up. Oh, it's just a sesamoid. Why would I get all that study, all those studies? Yeah, you get all those studies to differentiate the 14 things it can be. You know, sesamoiditis, ironically, that's the term that's used for that. I mean, sesamoiditis is very rare. You know, I don't see it very much, but I do see all these other problems. So that's what we're trying to do, is make the diagnosis. Again, on the sports medicine patient, it behooves us to do that, because in the big picture, it's going to save us time, and it's going to be efficient, and it's going to send you a lot of patients because you took the time to work it up and you worked it up well.
I'm interested in how people would react to, or how their answer would be regarding treatment, whether it's a stress reaction versus treatment of a stress fracture.
Yeah, if we had a navicular and the bone was a stress reaction and they were symptomatic there, a lot of times the stress reactions, the time is cut in half. If you're going to treat them conservatively, like let's just say the tibia, for example, you get a stress fracture of the tibia, that's a 3-month proposition of protection. If it's a stress reaction, it could be 6 weeks, 4 to 6 weeks. That's what it means. Yeah.
Treatment's the same, it's just the time, right?
Yeah, in those cases, yes. The treatment would be protection and follow them until they heal.
Rich, I thought we'd take a moment just to talk a little bit, and I do want to see, you know, some of the kind of the most memorable schemes that you came up with, the Tic Tac Toe for the Achilles injuries, and then of course the newer mapping out that you did for the sesamoid. But maybe we can take just a quick clinical break, and I want to see how you would react, and David, to a case that I had that was kind of tricky in that it presented with multiple things at once, and that's part of the time management piece that you were both talking about. So I'm going to show you guys an X-ray, and I'm just going to. Do you want to unshare the screen for a minute, and then we'll have you take over again, Rich?
Yeah, I'm gonna.
If you're able to do that.
How about that?
All right. So, and I apologize because of the technology and so forth. Can you see this well, the front of the ankle, or not so well? It's a little bright. Yeah. So let me just see if I can get a little bit of better lighting. Is that lighting any better? So there's a little bit of an anterior beaking. This is a 46-year-old.
You got to bring it into the center it better.
I think it's a little bit better now, and it might be as good as I can get it on this.
Raise it up a little. Okay. What are you looking at?
So this is a 46-year-old soccer player, and he presented with both ankle and heel and fascia, arch pain. That's how he presented when I first saw him. He's a coach, and he's from the UK, and he's kind of a hard drinking son of a gun. And so I got ankle, and the AP of the ankle looks reasonable joint space. I think the lateral was more impressive. How would you guys work that one up? And I'll tell you what I did and what he did on the subsequent visit. Would this be one where you would do your ski jump? I know it's not the best visual, but would you do your ski jump test on something like that, or is that enough? It's a very minor beak on that in terms of the ones that you refer sometimes for scopes.
Yeah, I mean, there's no problem. I would do that as part of the exam and seeing if he has this ankle pain that's is it general?
It was pretty much right along the joint line, right along the ankle joint proper.
Yeah, so, that would be part of the workup, is doing a Malloy test and a skier's crouch test and see if you can reproduce some symptoms.
And I did not do that ski jump test, by the way. I did more palpation and check for a drawer sign, of course, and those kind of things. Drawer was negative. He was pretty acutely painful though at that time.
And
so
did he have a history of injury?
He no other than sprains on the soccer field, so
okay, but no sprain, and then he comes to your office.
No,
Sprains in the past.
exactly, no acute episode, right? So it just seemed.
But it was sudden onset pain.
Yes, that was the situation.
And what about swelling, redness, heat?
There wasn't a lot of there was minor warmth, but it wasn't too impressive.
And no history of any gout or anything like that?
Well, I'm glad you asked that question, because he did relay a history of gout. He did relay in the past. He's a hard drinking guy, and he related a history of gout.
Well, that's a big deal. In the history part.
Right.
Because he's drinking, especially if it's hard liquor, and he has a history of gout.
But it had been episodic and not chronic. So what would your next move be? I can probably guess, but I'll let either one of you blurt out what you would do next.
Where was the pain? Where was most of the pain?
Most of it was in the arch, the heel, and in the ankle proper, all around the ankle joint.
Ankle joint, arch, and heel.
Correct.
Only 1 foot, unilateral.
Yes.
So
a little bit on the other, but mostly on the right foot.
You did your exam and you got screening x-rays, which were kind of equivocal.
Right.
But they told you some things, like it didn't look like he had arthritis in there.
Just a little bit of wear and tear and minor anterior impingement, but not I think the cases that you end up referring for scopes or doing scopes on. Yeah.
Well, plus he had a history of ankle sprains, which, maybe he has a smoldering osteochondral or chondral lesion. We don't know. And then this history of gout is problematic because although if he's having a gout flare, you'd think he would have greater symptoms, right?
That's exactly what I thought. And to move this along so we don't run out of time with your tests, I will tell you that I did not seek a uric acid at that time. I probably should have gotten a serum uric acid. I gave him a compressive sleeve for his ankle. And he was going, by the way, to a coaching session down in Florida. So I didn't have a lot of time with him. He was going for like a couple weeks. And then I dispensed an arch support. I took him through some exercises with stretching and so forth of the fascia. And then I cast him for custom orthotics. So I got him something in the immediate, like an immediate OTC support, and then casted him for orthotics. And then he went on his way. He came back a month later in even more acute pain, and in the arch and ankle area, a little more warmth. And now he was also getting a little bit of pain in his big toe. And that's what happened on visit 2. I do not have x-rays of the foot to show you, but most of the pain was not in the big toe. Most of it was centering around the ankle, which was now more acutely painful. What would your next steps be?
So
go ahead, Dave.
So clearly, you're treating the guy, but you haven't made even a tentative diagnosis here. He's got this, could be kind of complex. I clearly doubt it's a gouty thing, especially initially. So your guess wasn't going to tell you much, but now it's time. Now I think it's time to get labs, and I like the idea of injecting the ankle just for diagnostic, and see if that's a relief of pain.
Now in this particular case,
you're starting to treat him mechanically, orthopedically.
Yeah.
I think you now got to rule out any kind of systemic arthritis.
Right. And this will be an interesting caveat to bring up in terms of what you both think about using Colchris as a quote therapeutic sort of diagnostic test. So I put him on the regimen for the Colchris. 2 immediately, followed by 1 in an hour, and then 8 hours later another one, and then subsequently he was on Colchris for a while. That only helped slightly, okay? And again, at that particular point, I did not, and I should have gotten a uric acid. In retrospect, I should have gotten uric acid and not just done the Colchris. As we both know, though, that can be a little misleading in terms of that. And he was off to like another clinic. So he called me shortly after that over the weekend. Very little relief from the Colchris. Decided at that point to get a second opinion. He went to an orthopedic, diagnosed him with gout. Did not feel that there was that much going on with the ankle, and by the way, his arch was still bothering him quite a bit too. And then he put him on prednisone, to which he responded. So the only reason I bring this case up for both of you is just to interject that sometimes it's not as classic and clear cut. And I wanted to introduce a little bit of variability and what we see in the real world, where it's sometimes, I think I got a little off track, and in his mind, he was disappointed that I didn't get the uric acid, even though I was trying to do how shall we call it, the therapeutic diagnostic Colchris testing. What do you guys both think about Colchris for a gout rule out? I don't think it's quite as.
Wait a minute.
Go ahead.
I think you misunderstood when I said labs. I'm not specifically saying uric acid. I mean, he could have a systemic an immunological problem. But there's lots of different arthritic issues, inflammatory arthritis. Gout is probably one of the least things one of the last things that I would think about. But there could be multiple things. So
He did talk it up more in the second visit, and that's why, with the history, I then correlated that's probably what it was. But go ahead.
When you're doing labs, including kidney function too, just to see what's going on there.
Sure.
But prednisone would be a great choice. But I've used Colchris when I suspect gout, in an acute gout. But if they're not responding in 2 days, then that's you're not dealing with the gout problem.
Well, but he responded to the prednisone pretty well. So what would you?
But that could be anything. That's not diagnostic.
It could be indeed.
Right? It could be any kind. Prednisone's an anti-inflammatory. Colchris is not an anti-inflammatory.
I felt at that time, because of the quasi localization, where he was also having the big toe pain, that it probably was gout. At any rate, sometimes we don't always have a firm diagnosis, and I will follow up with him. We've still been in communication, and eventually find out what his uric acid was and how he's doing.
So let me interject real quick.
Sure.
Because he came in, and I agree, before I would treat his gout, first I would make sure he has, and during an acute, subacute attack, you may need to do a synovial fluid analysis. That would be the way, because the uric acid is going to be low during that acute attack. It's only going to be high when he's not having an attack. So serum uric acid levels may be normal during the acute attack, so you may miss it. So yeah, I'd stick a needle in it and get synovial fluid out. And especially if I was going to treat that, I wouldn't treat it without having that though, because we don't know. I mean, the guy could have a osteochondral lesion of his ankle, and every time he uses it, it starts to hurt and flare up a little bit. I mean, if he had a true acute case of gout, I'd also be worried about a septic joint. That's the reason. Pain out of proportion, hot swollen joint. Yeah, it's gout or a septic joint. The only thing that's going to tell you.
Well, it was warm. It wasn't red and intensely warm, but at any rate. Yeah.
But anyway, yeah, again, it gives you the validation of whatever. We see the serum uric acid, or maybe it's pseudo gout. Who knows? It's crazy. It could be a lot in the differential, and
sure.
That's why you're going to get that. And I wouldn't necessarily treat them until you know what you're treating, okay? Because and he's like, oh, and he probably said, oh, I didn't like what you did. I'm going to go see the ortho guy, and he puts him on a generic. I mean, all the prednisone did was take care of anything inflammatory. It could have helped him with his, if he had a chondral osteochondral lesion, could have helped him if he had some arthritis, could have helped him if he had a gout attack. So that was kind of an empiric treatment, and the guy's better, but what's his diagnosis? You know, he's saying he has gout. Well, does he have gout of his arch, gout of his heel, gout of his, I don't think so. So it's yet to be determined what that guy's diagnosis is. And, again, if I'm treating the guy and I don't think it's gout or a septic joint, I'd get a bone scan. Bone scan's positive, I'd get a CT scan. I would. I'd just get that study. I would only say, because I want to make a diagnosis. If the patient complains, just say, hey, do you want the diagnosis or not? Because I don't know what's going on. I tell them just like that. I don't know what's going on. I examined you twice, 3 times, and I can't come up with the diagnosis. So help me out here. We need some help. Yeah, I'd be aggressive on really finding out what it is, especially on some guy who's active, because, we all deal with difficult patients, and sounds like that guy was looking for the quick answer and be on his way, and his history, maybe he has got some other comorbidities that we don't know about. So
Fair enough. And before we jump back, I want to just share one other case that I actually called David on. It was a swollen red fourth toe, erythematous fourth toe. And this was a virtual visit that started. So just imagine the DIPJ and PIBJ a little swollen, but the base of the toe was not swollen. So it was at that demarcation. She's a diabetic. She had a history of a corn and a little ulceration on her 5th toe that subsequently healed. She's also had gout. So we've got several things in her history. No open ulceration on the 4th toe. So I saw her first virtually. She was away, and I thought that it might be gout. It sounded like a flare. So I did write her for some Col-Cris before she could come in, and that did nothing. And then I saw her the following week when she returned, and I thought that, well, maybe it's some some very low level infection. The bone, the X-rays were not impressive, and there was no break in the skin. So I put her on a short course of Augmentin, and that did nothing. And then finally, I ended up calling David. What do you think of this? And David, do you remember this case? Do you remember what you told me?
You sent me a couple pictures, right?
Yeah, it was a swollen 4th toe, just at the distal end of the toe, at the PIPJ distal.
Was that the one I thought might be related to a mucoid cyst?
That's right.
That's
and
the
so,
one, okay.
so what was your advice on that?
To just give her a drop of steroid in that area.
And it worked. It worked. So I'm convinced that that's probably what it was. And I think the point of that, and Rich, I'm happy to hear your thoughts on it, but this was kind of like diagnosis by trial. She had a history of cellulitis in the past in various areas. She was diabetic, so I had a high suspicion that she might have an infection. That did nothing. And then also the history of gout, although it wasn't classic for gout in the 4th toe like it was. Do you have any comments, Rich, on that?
Yeah, I see a lot of dactylitis. We all do. Spontaneous onset. I'd be thinking rheumatoid arthritis, ankylosing spondylitis, and specifically psoriatic arthritis. Dactylitis is the hallmark sign of psoriatic arthritis. And again, I would just have those on the differential. Turns out to be a mucoid cyst possibly. And again, an MR there could probably show that mucoid cyst as well. So again, just trying to validate things before treatment, I think is a good idea.
All right, let's jump back to your presentation with your tic-tac-toe and your sesamoidopathy.
All right, so posterior heel disorders. Everything on the posterior heel is not a Haglund's deformity.
You gonna share your screen, Rich?
Oh, you're not seeing it?
Not yet, not just right yet.
There you go. Okay. Except Oop, there you go.
So yeah, this is a specific interest of mine. And before we start talking about posterior heel disorders, there's a lot of different problems to talk about. We got the bump problems like a pump bump, which is commonly lateral, sometimes less commonly medial. There's Haglund's deformity, prominence of the posterior superior process. And then we have the effect of the tendon, insertional tendinitis, especially in kids. I see that quite a bit. Then we have in the older population, tendinosis, with or without spur, the so-called retrocalcaneal spur. I call it Achilles insertional calcific tendinosis. And then there's a diagnosis I came up with. I see it a lot. It's at the junction of the Achilles tendon and the plantar fascia, posterior inferior in the back. It's right at the junction of the Achilles tendon and the plantar fascia, and I call it Tendo Fasciitis, for lack of a better term, because that's where they hurt. If you were to get an MRI on that, you'd see fluid there. You'd see a bone reaction at the tendofascial junction. And so that's an important diagnosis to differentiate. But the point being is it's very important, especially if it has to do with any surgery, to map that out, to differentiate what is the diagnosis here. And what's helped me immensely is this Tic Tac Toe Grid, because the surgery back here is a very challenging it's very challenging back here when you're doing surgery, because it has to be so specific, and you're trying to protect the Achilles tendon, and sometimes you have to split or release it possibly in order to take care of the problem. So it behooves us to have the diagnosis. So here is the Tic Tac Toe Grid. You can see it, 3 squares for the upper third, middle third, lower third. The upper third has no tendon attachment, okay? The retrocalcanea bursa is between the bone and the tendon right there. Adventitious bursa can be on the sides where the pump bump is, or in the back. That's between the skin and the bone posteriorly. But if we're talking about an insertional calcific tendinosis, here's a good example of it here. These 3 squares, this is the heart of the insertion right here, this middle square. That's where the Achilles inserts, and it inserts on the sides as well. And there is an expansion, more developed medially than laterally because of the plantaris insertion, okay? So a pump bump classically would be lateral here, these 3 squares. A pump bump medial would be these 3 squares. A Haglund's deformity would be these top 3 up here. That's where Haglund's is. You get the posterior superior process and the adventitious bursa, or the retrocalcaneal bursa, excuse me. The insertional spur is usually here, okay? And then these squares can be involved as well. If you're doing surgery on this, wouldn't you want to know if these squares are involved? Because when you make an incision back here, that means you're going to have to get to all 6. So anybody who makes a linear incision on the medial side and says, I did this retrocalcanea, or I did this insertional calcific tendinosis problem, I ask them one question: through this incision, how do you get over here? You don't. That's the problem. You don't. So you don't expose it and you leave it there, and post-op, the patient has continued pain there. So this is your roadmap. This is your roadmap, and where these X's are where the patient hurts, and that means in surgery, after I make this incision and split the tendon, I know I need to get here, here, here on this particular case. All right, so.
You use this grid, Rich, with avoidance of the sural nerve?
Yeah, sural nerve. Sometimes there is a branch off the sural nerve, because I have seen cases. I had one myself, but I saw 3 or 4 others. Occasionally, they have neurogenic symptoms. But when you're making these incisions in here, yeah, I look for any, and it's not the sural nerve, it's a branch off the sural nerve, okay, just to be clear. But yeah, I had a couple of cases, this one lady in particular, it was very challenging. We actually had to make an incision, find that branch, and I cut it right when it intersected the sural nerve. Luckily, we were able to find that with a microscope. But there you go. Normally, nerve problems aren't a problem back here, normally. but occasionally there's an anomalous nerves. I have seen one as well medially off the posterior tibial nerve coming back this way. They shouldn't be there, but they can be there, okay? So this is invaluable to sort out all the different posterior heel problems. And again, just remember, all posterior heel pain isn't Haglund's deformity. It needs to be well defined. And there's little to no research. I mean, this is grouped into insertional Achilles problems, zone 2. Zone 1 are non-insertional Achilles. That's the classic watershed area that we all deal with, where the tendinosis occurs. So zone 2, zone 1. Okay, this is 25% incidence. The zone 1 is 75%. So 3-to-1 ratio of zone 1 to zone 2. So zone 2 is less common, but it's very important because the tendon is there. And I see some bad surgery back here. Okay, it's usually due to inadequate resection of the spur and damaging the insertion of the Achilles. You got to treat this with all the respect we can treat it with, just to preserve it, okay? And these expansions on the side, medially and laterally, those are the anchors. I mean, I can get in there surgically and totally detach the Achilles in the back. And if you leave the expansion on, this tendon will not retract up like all tendons would when you cut them. Okay, so this expansion is very important. And we actually did a study that's not published, and we describe very specifically the presence of a well-defined medially and a less defined lateral expansion of the Achilles. And that's important to know, because that you want to preserve that. And sometimes I see symptoms there. Patients come in and they hurt on the expansion. They don't hurt in the Achilles, they hurt way on the side. And so that works really well with injections because there's no risk. You can actually put fairly potent steroid in there because the insertion is here. You never want to be putting Kenalog here, right? You wouldn't want to be doing that to the insertion of the Achilles tendon. You want to avoid that. Occasionally, if there's one square like down here or the expansion, you can inject that, no problem. Usually a series of 2 to 4 injections, 2 to 3 weeks apart, takes care of that. Also, this tendofascial area is right here where my arrow is. It's the intersection, the junction of the Achilles tendon coming down. It gets thin here. In babies and fetuses, it's really thick, but in adults, it's really thin here. And then the plantar fascia, it's the junction, the tendofascial junction, especially in rheumatoid patients. They get this Tendo Fasciitis. And the good thing about it, it responds extremely well to steroid injections. And there's no risk of damaging the main Achilles insertion up here.
So we can get to your other one, Rich. Can you tell us about the Sesamoid Grid you developed?
Okay.
I think that's your next slide.
Yeah, and this may be the last one, huh?
We'll do one more after that, and then we'll, because we'll mention neuromas maybe.
Okay.
Go ahead.
And then sesamoidopathy, sesamoiditis is what it's called. I call it sesamoidopathy. And there's like 12 different things this could be. And again, I'm into this grid, you know, trying to come up with reference points, anatomic reference points. So when we get down here, and here you can see this illustration. This was for a book chapter I wrote on sesamoids just recently. And so there's 3 zones. And back here, what's back here? Flexor brevis muscle turning into tendon. And yeah, we see tendon strains. We see tendon muscle injuries. That is the weak link, especially in dancers back here. I've done a lot of shock wave on some of these brevis partial tears. You can sometimes, if you can get an MR and you can actually see a tear at the junction of the brevis muscle and the tendon. And then this is the sesamoid zone. You got the tibial and fibular sesamoid. And then there's 3 points on each sesamoid you would palpate: the distal pole, mid aspect, and proximal pole. Same here. So there's 6 points on both sesamoids in total. The nerve, which is neuritic sesamoid pain, there's no papers written on it. There's one letter to the editor from 1950. That's all it's in the literature on neurogenic sesamoid pain. And that is a very subset of sesamoiditis. It's not the sesamoid that's the problem, it's the nerve. And the nerve lives right here and right here. Okay, and you can palpate it like a lamp cord sign. And then you get up here in the zone 3, this is your big toe joint. What if you had a plica? What if you had a chondral lesion? What if you had hallux rigidus? Whatever. It's not back here. It's not the sesamoid that's hurt. It's the joint that hurts. Okay? So this is proximal of the joint, or excuse me, proximal of the sesamoids. This is distal to the sesamoid, zone 3. And the sesamoid zone is 2. So here's where you want to spend your time and say, okay, you got a bipartite sesamoid, they're going to hurt mid-aspect. You got an avulsion fracture, they're going to hurt distal. So if you take the time to examine, you can separate, you can differentiate a lot of the pathologies just based on that. Is it truly the sesamoid that hurts, or is it the surrounding tissue that hurts, like the nerve? If the nerve's involved, sesamoid has nothing to do with it. Just happens to be there. Okay. So as far as the tests go, palpation is a provocative test. And then pain unassuming the demi-point position with loading. There's not one sesamoid problem I know of when you load them in a demi-point position that they're not going to hurt. Because in that, when you dorsiflex the hallux, you're locking the sesamoid against the metahead, and then you're going to load it. And that will show its face. I mean, they'll definitely hurt if it's the sesamoid. And then you also want to check for instability. Like on the lesser toes, you do the Lockman or dorsal drawer test. You want to test it here too, because you can get a insufficiency of the plantar plate. The plantar plate's incorporated into this plate that has the sesamoids as well, and the flexor brevis coming in, slips of the plantar fascia, etc. So in acute, subacute setting, you can have plantar plate tears of it, and you'd want to know that. It's the same workup you would do for the lesser toes. You're going to do the Lockman test. You're going to maybe get an arthrogram, CT arthrogram, MR arthrogram, or X-ray arthrogram, and there's going to be dye leaking out of there. That would make the diagnosis. And they would have instability on stressing it. Okay. So anyway, that gives you...
Yeah, you know what I was going to say
I think the key takeaway here is I'm not sure there's such a thing as sesamoiditis. And I think there's a lot of people taking sesamoids out for no reason. I mean, your points are excellent on this.
And Rich, you've got several other things, and David had an excellent suggestion, is to maybe when he's holed up in Buffalo with snow and has got nothing better to do, and also when people have a chance to digest and maybe even think of a couple things that come out of the meeting in October. And what's doing there, we can have a teaser for you to talk about some of the exercise-induced things that you've written papers on, and then some of the controversies with neuromas and a couple of the other tests. But let's open it up for any of the remaining stragglers for questions, because it's been great information. I love it. I eat it up. Some people, it's a bit overwhelming. So does anybody have any questions right now for either Rich, for David? I'd be happy to give my 2 cents. Anybody that is still watching and has any questions? Well, I'm going to give final words to both my guests, David, which you summed up some things in terms of the perspective. David, I'll have you start, and then Rich, you'll have last word. Go ahead, David.
No, I think it's all about. I think Rich's point is well taken here. It's all about diagnose before treat, and make a differential diagnose and test appropriately, and time management. Those are the key takeaway points here for all these cases.
Rich,
and I would just say,
go ahead.
I would just say in closing, I would encourage everybody to follow this pathology template, and you can do this on your own. You could add your own touch, your own personality to it, but come up with your 1 or 2 provocative tests for each problem you see in your practice. Now, when you see something that you don't know about, just look it up. It takes, you can do it very quickly. It's amazing the technology we have now. And that's how I put most of this together. It just takes a little bit of time, and you just do one entity at a time. And then all of a sudden you have, I got like 75 of them now, you know, and maybe we'll have to put it in more of a formal, like a booklet or something. I don't know, you know, it's always like, well, you should write a book on it. Yeah, I should do a lot of things, but right now I'm trying to enjoy retirement. So,
Well, at least we've
yeah.
had a
I'm
little
just trying
bit
to
of a,
share. I'm
Sure.
just trying to share the information, and you can do it. Everybody can do this on their own. That's what I would say. And it's definitely worth doing, and it will improve your efficiency, whether you're fee for service or capitated. Doesn't matter what system you're in or what it's going to be in the future. We still have to make the diagnosis, and it's as simple as that. And it's kind of a fun thing to do as well. So
do you want to close
don't
out your,
hesitate to call.
do you want to close out your
text me or
share
call me,
screen?
let me
And
know.
yeah, do you want to close out your share screen? And then I just want to thank you both for participating. Great information. One last chance if there's any questions from the peanut gallery for anybody that's stuck it out. We're going to do this again maybe in about 6 months, maybe December, January after the Seattle meeting. There'll be probably some information there that might have some more interest. And I'd like to do it in the same format if I can keep you both on the hook to do this again. And then Rich, you can talk about some of the other work that we didn't get a chance to talk about tonight. I am going to ask you what I'm trying to make a habit now, since I call this Fitfoot U, of asking you how you guys are maintaining your own shape and physique. What are you doing, Rich, to stay in shape?
Well, right now I'm 11 weeks after some knee surgery. So
how are you
I've
rehabbing?
been working hard.
Yeah,
and
you
the knee
swimming
surgery's
at all?
taking a little longer. I'm trying to prevent the need for a total joint. So I have high hopes that I'm going to be back. But before that, I was staying active. Just, you know, my goal when I retired was to be in the best shape I've ever been in. And I did achieve that goal. Now I got to maintain it. So now I got to get it back because I just lost 5 months.
Are you doing swimming as part of your regimen? Because that really helps.
Yeah,
with
actually,
swelling.
that was the one thing. The pool workouts, I was running in the pool at 2 weeks after surgery. Yeah, which was amazing. And yeah, I come up with some exercises. You know, I was walking in the pool, then running backwards in the pool. Very challenging.
Now, how old are you? How old are you now, Rich?
67.
You don't look a day over 58, let's say. And David, what are you doing to stay in shape?
Oh, I'm working at that. I recently retired also, like Rich. So I'm actually now have time to do some really good workout, weight training, elliptical, doing cardio almost every day. So it's kind of fun.
Yeah, and you might. I'm going to have this guy Bladgrove in a few weeks or a couple months. He's like the world-renowned strength and conditioning coach for runners. He's worked, I guess, years ago with Usain Bolt. So that'll be an interesting thing. But they're more and more they're talking about strength weight training as part of a necessary thing for keeping, not just doing running, in other words, not just doing intervals, as a necessary part of injury prevention and performance.
If I knew then what I know now, it would be all different. I would have decent shoulders, decent knees, decent hips, you know, everything in moderation. Right.
That's right.
I'll be
Listen, thanks again for everybody that participated. And I look forward to, you know, in winter and after the Seattle meeting, and hopefully I'll get to see both of you in Seattle and read it and all the other Academy members, as well as anybody else that ventures out that way.
Sounds
Thanks
good,
for having us,
Ben.
Ben.
All right. Good night,
Thanks,
everybody.
All right.
Bye-bye.